Welcome to part 4 of respiratory. We're going to focus on atelectasis. Atelectasis is a very common respiratory condition in healthcare, especially in hospitals. Atelectasis is when the alveoli are closed or collapsed. This means that they cannot open back up without help. Atelectasis can be chronic or acute, but acute is most commonly what we're going to see, especially in the post-operative period. Atelectasis can involve a small amount of alveoli or large amounts of alveoli, which can involve the overall lung. Many disorders can cause atelectasis. Basically, anything that stops air from opening the alveoli is going to cause atelectasis. There are two types of atelectasis, non-obstructive and obstructive. Non-obstructive atelectasis occurs from reduced ventilation, like not taking deep breaths after surgery, not taking deep breaths after pain medication, the pain medication decreasing our respiratory rate and volume, and then laying supine for a prolonged period of time. Obstructive atelectasis is the more common type of atelectasis, and this occurs from something stopping the air from getting to the alveoli. This can be from aspirating a foreign body, a lung tumor, secretions, impaired cough, and even fluid accumulation in those pleural spaces. Whichever type we are dealing with, the same concept occurs. The air is not getting to the alveoli to keep them open, so the alveoli close and they stay closed. The post-operative period has the highest risk and occurrence of atelectasis because the person is in pain, they don't want to take deep breaths, anesthesia causes smaller breath volumes, so they're not taking deep breaths. The person might be immobile, which means they don't have to take deep breaths. And depending on the surgery, they may have some abdominal distension that pushes up on the diaphragm and doesn't allow them to take a deep breath. The lack of deep breathing post-operatively causes those alveoli to close and stay closed, and then we have to force them open. The symptoms of atelectasis usually come on gradually and get worse with time. The patient can have dyspnea, a cough, sputum, and they're going to start to have crackles or rales, usually starting in the base of the lungs. The crackles are noises the alveoli make when they're popping back open. The pulse ox level can decrease, sometimes to below 95%, but if large areas of lung tissue are involved with the atelectasis, the patient may develop respiratory distress, tachycardia, tachypneic, pleural pain, central cyanosis, which is actually a late sign, and that's when the skin is starting to turn blue. The person can also have anxiety, and at this point, the pulse ox is probably going to start dropping below 90%. The reason why the person develops these symptoms is because the body is getting very little oxygen. The heart is struggling to work to get the little oxygen they have circulated around the body when the heart itself isn't getting enough blood either. When we do a chest x-ray, it may suggest a diagnosis of atelectasis before clinical symptoms appear. So you might see atelectasis on x-ray, but we don't hear it in their lungs, or they may not have symptoms yet. Chest x-rays usually lag 24 hours behind clinical symptoms, especially with improvement. So we will see that the person is clinically getting better, they feel better, their SATs are doing better, but that x-ray may still show atelectasis, and that's okay. As long as that clinical symptom is improving, the x-ray will catch up in time. Managing atelectasis is really about improving ventilation and removing secretions and getting those alveoli to stay open. Interestingly, the same treatments we use to manage atelectasis are also the same treatments we use to prevent it. The best thing we can do is frequent turning, getting the patient up to the chair, and early ambulation. When we move our bodies, we get forced to take a deep breath. That deep breath is going to help open up those alveoli. We also want to have the patient do lung volume expansion maneuvers, like using the incentive spirometer and doing like deep coughing, not like, but like deep coughs. There's a concept called ICOUGH, I-C-O-U-G-H, which stands for incentive spirometer, coughing and deep breathing, oral care, understanding the why of doing these, getting out of bed at least 3 times, and having an elevated head of the bed. I love how they made this an acronym to help people remember what to do, because these things are all basic nursing care that we should be doing on every patient, especially post-operative patients. My whole job in the CVICU after I got my patients stable was to do ICOF all day long. In addition to ICOF, we can administer bronchodilators either by a meter dose inhaler or by SVN, or sometimes they have little positive pressure devices they can attach to an SVN to help push the medication in, but not everywhere uses those. Bronchodilators work to open up the airways. So they're opening up the trachea, they're opening up those bronchioles all the way down to the alveoli to allow more airflow all the way down to the alveoli, and they also help expectorate secretions. Similar to what parents do to babies, we can do a thing called chest physiotherapy. Most of the time, respiratory therapist does this, but nurses can do this as well. And chest PT is when we actually beat our hands on the patient's back, just like we're burping a baby. And the act of beating them on the back is going to move those secretions in their lungs, and hopefully they'll be able to cough them out. If our patient starts having severe respiratory distress from atelectasis, we may have to intubate the person and mechanically ventilate them. Intubation and mechanical ventilation is a Block 4 topic, so you don't need to worry about that now. If we have atelectasis that's related to fluid accumulation in the pleural space, we can do a procedure called a thoracentesis, where we insert a needle into that pleural space and we drain the fluid out. I want to discuss incentive spirometry a little bit. Incentive spirometer can be a lifesaver. Incentive spirometers are small little plastic devices that encourage our patients to take a slow, deep breath, forcing those alveoli open. There's no motor, no mechanism, just the person taking a deep breath. We want the person to use the IS 10 times an hour every hour while they're awake. To use it, they need to sit up, preferably in a chair and not slouching like the picture on the right. The kid in the picture on the right is not doing his incentive spirometry correct, so this is a picture to show you what not to do. The mouthpiece is going to go into the mouth, and the person's going to take a slow, deep breath in, trying to keep the dial on the left-hand side of the device in the best category. At the same time, the indicator rises to that good, better, or best indication. There's an indicator in the middle of the device that's going to rise to indicate how many mLs of air the person's breathing in. The amount of inhaled air can be set to a goal for the patient, which hopefully is going to incentivize them to breathe deeper to meet that goal. I attached a link right here for a video so you can get a better idea on how this actually works and what it looks like. And I called an IS a lifesaver. I call it this because I have seen the incentive spirometer stop people from needing to be intubated and put on a ventilator. I have seen it stop pneumonia from happening after surgery, and I've seen it reverse fevers after surgery. Post-operative fevers are pretty common, and they're due to atelectasis. And I want to share something to you that one of the surgeons I used to work with shared with all of his patients on why people get post-operative fevers. It's cute, it's peachy, and I like it, so I want to share it with you. When our body is under anesthesia, we don't want to take deep breaths. When we wake up, we're in pain, and we don't want to take deep breaths. So then we start to develop atelectasis. Post-operative atelectasis is keeping the hot air in our body, and that hot air gives us a fever. By doing our incentive spirometer, we're forcing the lungs to open up, blow out all that hot air so the fever goes away. And I just love it because it's such a great way to lower the information we're giving to the patient on a level that they can understand. Other things nurses can do is to educate our patients on optimal respiratory functioning, including lifestyle choices and behaviors that are healthy. This can include smoking cessation, exercising, nutrition, wearing masks around sick people or just avoiding sick people altogether, and then staying current on their vaccinations like influenza, COVID, and pneumococcal. We can educate them on staying away from highly polluted environments, and we can educate them on anxiety-reducing strategies to help their breathing be easier. If someone's breathing too quickly because they're anxious or they're in pain, we can teach them to breathe in through their nose like they're smelling a flower and breathe out through their mouth like they're blowing out a candle. And we call this pursed lip breathing. This type of breathing is going to force the person to slow down their respirations. We can also help people find positions that provide comfort to help their breathing, like sitting up in the chair. And we can promote coughing and deep breathing exercises like the incentive spirometer. And we can educate on the importance of moving around and ambulating, especially after surgery. Now, all of these strategies should be taught to every single hospitalized patient, especially our postoperative patients, and many of these are going to be on our plans of care for all of our patients. And this is the end of part 4.